welcome to our Facebook Live question and answer session. I am Dr. Kaldas of the Kaldas Center, and I'm looking forward to answering your questions and hopefully putting you on the right track to live a better, healthier life. Briefly, I'll review what the Kaldas Center does. The Kaldas Center tries to solve problems for women who are having challenges with pain or with fertility, or if they were born a different way, problems that many doctors maybe have seen and told them they were unsolvable. We love patients who have stories like, well, I've been to 3 different doctors and no one can help me. Or, I was told by my doctor that I'd never get pregnant. We just love stories like that, and bring them on, because we will find a solution for you almost every time. And we do it, this is what we enjoy doing, and so we welcome the challenges. This is our, not that any one of you is average, but if you're average in that regard, that everyone has said that you're just exceptional and they can't help you, then please come on over. So thank you everyone who submitted questions on Facebook already. If you have not sent in your question yet, feel free to post it to Facebook Live, and we will do our best to answer the question. If you'd like to submit anonymous questions, please contact us using Facebook Messenger and indicate that you'd like to share your question but remain anonymous. And we would be delighted, because we want to protect your privacy. We don't want anyone to be uncomfortable when they are asking questions, because there is no such thing as a stupid question. And if you've had 10 doctors give you an answer that you don't like, let's think through it. Let's just have a fresh eyes, fresh brain on the situation, okay? That's what myself and Dr. Menya and Dr. Wong are here to do at the Kaldas Center, okay? Before we begin, a reminder that this question and answer is meant to be for information purposes only. If you have a serious health problem, make certain to contact your doctor. If you would like to contact us at the Kaldas Center, visit kaldascenter.com or call us at 920-886-2299 during normal business hours, and we'd be delighted to get your call and talk about whatever is challenging you. So let's go ahead and get started with questions. From Carrie. I've read a few stories about endometriosis spreading to other parts of the body, like the kidneys. I have endo. How common is this, and should I be concerned? That's a really good question, Carrie. Well, endometriosis is thought to spread 3 different ways, but the overwhelming majority of endometriosis is essentially by retrograde menstruation. Pretty much 100% of women have menstrual blood go backwards through the tubes when they have their period. However, only about 10 to 15% does the immune system not clear it out. And surprise, you've got endometriosis. You're the lucky, genetic lottery winner. And so endometriosis, however, can spread through the circulation, so from the uterus to the circulation, and then a small minority can actually happen by the lining of the pelvis essentially having changed to endometriosis, because it shares the same embryologic origin as the lining of the uterus, the endometrium, all right? So for example, I had one patient when I was doing my residency at Stanford, long time ago. I am much older than my youthful appearance would suggest, but every month she'd have her period and she would get a bloody nose. And believe it or not, she had endometriosis in the nose, and so that actually had to be removed, and so she wouldn't have that happen every month. So yes, it has been found in the thorax and the lungs and the kidneys and the brain, and so it can go all over the place. But most of the time, you don't need to worry about it. All right. Obviously, you want to just follow good endometriosis management practices. You want to, for symptomatic relief or for improvement of fertility, you want to debulk the disease. A little bit like cancer, but it's not cancer. You want to get rid of it. You want to remove it and then prevent its recurrence with one of several medical management options, so it slows or inhibits the recurrence of the disease, so you don't have that, you minimize the chance of it ever getting to your kidneys or such, and having, hopefully minimize the number of surgeries that you end up needing to have. Thanks, Gary. So Elizabeth writes, a member of my family was just diagnosed with polycystic ovary syndrome. We were told that changing her diet may help her symptoms. What foods should she avoid and why? Thank you, Elizabeth. We take care of so many polycystic ovary patients, and a lot of people just have a really hard time understanding polycystic ovaries. The way you should look at it is as a continuum. It's not you have it or you don't. You can have components of it. In fact, in Europe, it's strictly an ultrasonic diagnosis. Ovaries look polycystic, she has polycystic ovary disease. Now, here we emphasize a little bit more the syndrome of polycystic ovaries, which is an actual metabolic syndrome where throughout the body there is an insulin resistance. And so those patients will have about 10 to 20% chance of having diabetes the day they're diagnosed. And along those lines, the dietary modifications for polycystic ovaries should be no carbs, okay? Minimize the carbs, bad, right? Because the glycemic control is not good, right? And so you want to just eat from the periphery of the supermarket. And interestingly, if you are able to lose weight, and it's hardly possible when you have polycystic ovary syndrome, it's so hard to lose weight, and but if you do manage to do that, then your ovaries will actually start working a little bit better, and you will start ovulating. And obviously, because of the continuum, the spectrum of people with polycystic ovaries, I need to know more about the specifics. Is your family member, really thin and have polycystic ovaries? She never has a period, or is she rather heavy and has hair growth on her face and so on? All that stuff would play into more specific recommendations. But fundamentally, try to have a very low carb diet, and you'll have better glycemic control. Maybe consider an insulin sensitizer like metformin, and I think that is a good start. Okay, so thank you, Elizabeth. And Sandra writes in tonight, I believe my bladder has prolapse. I'm wondering what my options are to correct this. Also, are there symptoms that manifest when you're living with this? Is the bladder okay? Does it affect intimacy? Well, I think that's a great question, because we here at Kaldas Center, we do so much endometriosis and fertility work. This is one of the things that we in fact do an awful lot of, but doesn't come out as readily, as harder to find out about us. And so bladder prolapse can affect intimacy because it's in the way. When you're trying to have intercourse, it's like he's bumping into something, and it could even result in leakage of urine when you have intercourse because he keeps bumping into your bladder that's falling out. And so I would say that that is one of the ways that the bladder prolapse can manifest. Another way you can have is urinary retention, because the bladder is falling down and the urine has to actually jump a hurdle to get out of the urethra, and so you can end up with urinary retention or hesitancy, where you have you have to wait there and sit there for a while waiting for the urinary stream to begin. Frequently, the bladder prolapse is associated with a urethrovesical junction, the top of the urethra rotating downwards with the bladder, and you have incontinence. Like half of women who've had natural deliveries, not C-section, but natural deliveries, will have some kind of incontinence. Some of them quite bad by the time they're 50 years old. And they say to me, well, I thought it was normal, and I've been wearing a pad for the last 10 years or whatever it is, and I'm 45 and I avoid running and jogging because I dribble all the way down the road. And I'm like, oh my goodness, that's not normal, and that's so easily fixed. And it can be fixed rather easily with minimally invasive procedures that entail day surgery. So, but the bladder can be fixed, and there are two different kinds of bladder prolapse. It can be the fascia, the connective tissue, that the bladder sits on between the bladder and the vagina has stretched out, and the bladder is pooching down, trying to go through the vaginal opening. Or it can be that literally that connective tissue has come off of the bony pelvis. Like when you push those babies out, literally the fascia that holds up the bladder was pulled off on one side or both, and therefore then you have a lateral cystocele, a lateral bladder prolapse. And just you need someone who knows what they're doing to figure that out and then give you the options, both laparoscopic and vaginal, to suit your needs the best. Okay? In this day and age, you just should never, it would be sad to be opened up to have this fixed. If someone tries to open you up to have this fixed, then find the few who can do it without doing that kind of trauma. Okay. So anyway, thanks for the question. So a reminder, if you'd like to set up a time to speak with us at the Kaldas Center, you can call us at 920-886-2299 or go to kaldascenter.com. So we have a question anonymously from our messenger. Thank you. And is there a correlation between endometriosis, PCOS, and fibrocystic breast? I have not read about an endometriosis association with fibrocystic breast disease. Endometriosis fundamentally is an autoimmune dysfunction. And I know how confusing this is, but just because you have polycystic ovaries doesn't mean that you have cystic breasts. And a lot of people think that, but they're actually different entities. Fibrocystic breasts are the breast structure, okay? And you can have, if you have, with polycystic ovaries, you have high estrogen levels, and you can stimulate the breast tissue, and in that way, you can potentially have a higher chance, say, of potentially a little bit higher chance of breast cancer. But actually, fibrocystic changes in polycystic ovaries, no, I have not seen a correlation, and nor with endometriosis. Though the way these things are named, it can be very confusing. Like a lot of people think, oh, I have, a fibroid cyst, for example, a fibroid or leiomyoma of the uterus, and that, yeah, I have cysts in the breast too, but there's actually no correlation. But the nomenclature, the names of these things can be confusing. But thanks for the question. So Naomi asks, is VBAC a good idea? Is it safe, Naomi? It is safe depending on what kind of C-section you had. If you have had a low transverse cesarean section, that means a horizontal incision on the uterus. Mind you, not on the skin. The skin incision is independent of the incision on the uterus. So even if you had a bikini cut for a C-section on the skin, you need to be sure that you get the operative report for your obstetrician, unless they were the ones who did it the first time, and that it's a low transverse incision. If it's a low transverse incision, it's thought that you have about a 1% chance of a uterine rupture if you do a vaginal birth after cesarean section or a trial of labor after cesarean section, okay? And so depending on why you had the C-section the first place matters to your success. So if you had the C-section because your first baby was too big for your pelvis, then it's going to be a lower chance of success because probably your second baby is going to be just as big as your first one, or maybe bigger. And so then additionally, if you have had the C-section for a breech and they've never even tried a vaginal delivery and your baby's head down this time, well, good grief. You've got like a 70% chance, 60-70% chance of success this time. Or if you had it for an emergency thing like, oh, you're bleeding or the baby's heart rate wasn't doing very well and you had to do a quick C-section, then your chances would be pretty good of success. What I would recommend is that, so it's safe, but a lot of people come in and ask me, Rami, tell me which one is safer. So I can tell you that the very best outcome is if you try a vaginal birth, and it works, hooray, everybody's happy, everybody parties. If you try a vaginal birth and it doesn't work and you have to do another C-section, that's the worst outcome though. And if you just go ahead and do a C-section and don't even try a vaginal birth, well, you're not going to have a uterine rupture, and therefore there's no risk of uterine rupture almost, compared to 1% if you do try a vaginal delivery. So therefore, technically, a repeat C-section is quote-unquote safer, but you need to understand how small the risk of uterine rupture is, and you also need to be in a facility that is ready to handle this and have a doctor who is ready to handle this, okay? Because you're gonna find a lot of docs who discourage you because when you're in labor, active labor after 4 centimeters, they need to be there. You need to find out what group you're going to, how they handle this situation, because that's a big commitment on the side of the doctor. So it may be that, you know what, whoever's on call will be spending the night or whatever, staying in the hospital, because that is going to disrupt their schedules more. And you've got to have a committed team to having you succeed in order to have a successful vaginal birth after C-section, okay? Thanks for the question. Hey, from Danielle, I am terrified of having surgery, but it may be my only option with my endometriosis. How is laparoscopic surgery different from other surgeries, and how long does recovery take? Danielle, that's a great question. So, laparoscopic surgery compared to being opened up is far superior to treating endometriosis because you have magnification of the laparoscope and you just see it better. Now, I don't even know how to be politically correct about this, Danielle. There are people who don't know laparoscopy very well. Not all surgeons are created equal, just like not all teachers are awesome, just like not all lawyers are fantastic. And so you really need to find someone who knows what they're doing. Otherwise, it's a dangerous situation. And I don't even want to be, I'm not trying to be self-congratulatory. I simply see too much day in, day out. Find someone who knows what they're doing. And make sure they've done a lot of it, and have them explain what they're going to do. And if they're not meeting your common sense test as you're listening to them, find someone else, okay? And so a good place to go to for advice is either the Endometriosis Association of America or Nancy's Nook, a big blog that has like, oh gosh, I don't know, 80,000 followers or 100,000 followers. Wonderful resource. And they will tell you where the centers are that treat endometriosis. There are only about 98 in the country. Kaldas Center is one of them. So, another anonymous question, can endometriosis still grow after menopause? Technically, it can grow minimally, but it isn't thought to grow much because you have very low estrogen levels. However, if you're on hormone replacement therapy, you bet it can grow. It can be stimulated after menopause. And then there you are, 60 years old, having symptoms of endometriosis. In addition, there is a very weak estrogen produced in the fat cells in the body after menopause, even though the ovaries aren't making estrogen. And it's called estrone, and it's very weak, and it's not thought to contribute much to the growth of endometriosis. That does not mean that pain of endometriosis stops after menopause every time. The reason being is, throughout your reproductive years, this has been active disease, maybe if it hasn't been managed well, and you've got scar tissue, and your bowels are all twisted out of the way and everything, and they're making Z's and all this, and you know, your things are stuck to your bladder and this, that, and the other, and there are nerves growing into that scar tissue. So you can actually have pain with scar tissue also, even without active endometriosis disease. Thanks for the question. This is a great crew tonight. From Tara, what can cause incontinence and how common is it in younger people? I'm 34 years old and have been having issues holding it in for about 3 months now. Oh boy, Tara, they write whole books on what causes incontinence, but I'll try to give it to you in a nutshell. So there are, in general, thought to be 4 different types of incontinence. One of them is when you have stress incontinence, when you've delivered babies vaginally usually, and there is a pressure disequilibrium between the bladder and the urethra, and therefore you leak when you cough and sneeze or run or get on a trampoline or try to exercise. Number 2 is overflow incontinence, where you're actually holding onto your urine and it's like literally overflowing because you don't have the sensory perception in your bladder. Number 3 is where you have urge incontinence, where your bladder has decided it's going to get a mind of its own and it's going to contract when you don't want it to. And that is called urge incontinence, where you're like, oh my gosh, I got to get to the bathroom, and you're running and you may not make it. And you start before you get, just as you're sitting down or something like that, or not quite there. And number 4 is when you have intrinsic sphincter deficiency, where because of a neurologic condition, either the baby that you pushed out, taking 4 hours to push out, has mashed on your nerves down there so much at the bladder neck that has damaged the nerves, or you have diabetes or multiple sclerosis and it has affected those nerves and you can't hold it in because your sphincter isn't working so great. Multiple sclerosis can affect that bladder, and diabetes also, that bladder having a mind of its own also. So yes, at 34 years old, obviously one would need to know your history in detail, but a good practitioner can have a really good idea of why you are leaking urine from one single visit. And if they're worried about that, one of those things like an unstable bladder or your sphincter not working, then they may want to prove it with urodynamics, a simple study that doesn't hurt in the office. But if someone understands fully the things I just said, they'll be able to give you insight right away and give you options to get dry, because at 34 years old, you do not want to spend the next 60 years incontinent of urine, and you don't have to. So give us a call if you like. So from Skylar, what are your opinions on thyroid and fertility and miscarriage? My reproductive endocrinologist put me on Synthroid when my TSH was 2.94 after my second miscarriage and wanted it under 2.5. My family practice doctor said he wouldn't have treated my thyroid at that level, but he would just keep me on Synthroid because I ended up having a successful pregnancy after starting it. How should I go about maintaining my thyroid when doctors have differing opinions? Oh, you know what they say about opinions, oh my gosh. So anyway, so doctors are no different than other people, and they have different backgrounds and different experiences and different educations. And so I would I would go with your reproductive endocrinologist on this one. When you're trying to get pregnant, and when you're pregnant, it is recommended to keep that TSH. In fact, a lot of people say at or below 2. Not real low, but at or below 2. So I think that with the miscarriage, because thyroid dysfunction can have an impact on miscarriage, and if it's real severe, it can lead to a kind of dwarfism even, and it can lead to recurrent miscarriages. So if someone comes in and they have a TSH of like 12, because that TSH is really working hard to try to stimulate a dysfunctional thyroid, then most certainly that could have been leading to miscarriages. Now, that opens up the whole discussion about miscarriages, but that's another talk altogether. And so, but long and short of it, I would try to keep your TSH at around 2. And it's not a bad idea to get a free T3 and a free T4 just to see where they are, because they're truly the ones, the T3 especially, that is affecting the organs in your body, and that's the one you want in the middle of the normal range, okay? From Allison, can endometriosis develop at any age? And reproductive age is when it can develop, Allison. So it won't start for the first time in menopause, and then pre-reproductive age, premenstrual age, menarche is not going to happen, okay? However, very shortly after starting menses, then it can happen. For example, over the years I've had patients who had imperforate hymens, and they were having periods, but they didn't know it, and they were having horrible pain. And then what happens is everything is going backwards. Everything is going backwards. And the immune system is so overwhelmed that the endometrium just proliferates outside the uterus because it can't get out. And that's unfortunate when it takes that long to diagnose a teenager with that type of thing, and you end up with a kind of a bad start. But I have seen, because there's such a strong genetic predisposition with endometriosis, if like your mom had endometriosis or a sister has endometriosis, you're 7 to 10 times as likely to have endometriosis. And so, therefore, just off the bat, you're looking at over 50% chance of it if one of your first degree relatives has it. And therefore, if a teenager comes in, let's say 18 years old, she's been tried on a contraceptive pill to get rid of her periods, she's continuing to have pain, and that should be looked at. She should not have to go through the misery that this disease can cause throughout her youth until she finds, a doc who will listen to her and figure it out when she's like 25 or whatever it is. And so, yes, it can happen in teenage years also. So, a reminder, if you'd like to set up a time to speak with us at the Kaldas Center, you can call us at 920-886-2299 or visit kaldascenter.com. These are so fun. Now from Courtney, how do you spot the difference between postpartum depression and postpartum thyroiditis? If it's thyroid issue, how is it treated? Oh my gosh, Courtney, you just get some lab tests, okay? You get some lab tests, you do an exam, you feel to see if someone has a goiter, and if they do, get an ultrasound of it, see if they have a nodular goiter, but primarily you do a thyroid panel. And then if you treat it and everything is all better, clearly you know it was a thyroid issue. But that's the first thing you should do. This is a simplistic thing, and it should be done tomorrow for you if you're wondering what's going on with that, okay? Thanks for asking. And from Samantha, I recently began having serious feminine itching. This is new for me. What might cause this to start so suddenly? Well, common things are common, Samantha, and it's been a long, hot summer, and especially if you went swimming a lot or you were out working a lot, then you might end up having a yeast infection. However, there are a multitude of things that can cause itching of your bottom. And they include autoimmune dysfunction, like lichen sclerosis. They include not only yeast, but they include where the yeast actually gets into the skin, and it's called a dermatophytosis. And it also includes changing, it could be a contact dermatitis. If you changed your detergent, if you changed your soap, any of that can cause itching of your bottom, and it just takes a look and possibly a tiny, tiny skin biopsy to figure it out. Obviously, there are other things that can cause it, like dysplasia associated with precancer of the vulva, if you've been exposed to certain types of human papillomavirus, but that's less likely, and we don't want to, freak anyone out tonight, so it's less likely, and most likely, common things are common, and you might have a yeast that's grown into the skin. So from Karen, my mom was diagnosed in March of 2018 with uterine cancer and had a full hysterectomy. She's 72 years old, very healthy and recovered well and is cancer-free, but now has a hernia above her belly button. It gets very hard at night, and she seems to have new digestive issues, like gas pains. She's been back to her doctor, and I guess this is common. Would you agree? Umbilical or periumbilical hernias at laparoscopy or open surgery can happen when you put the fascia together. It's not unusual, and a lot of it has to do with how strong your fascia is constitutionally. Okay, meaning different people are different, and some people are more likely to get a hernia than others. Is it possible that that something squeezed through the sutures or something like that? It's possible, but most likely it's just that her fascia is of that nature. But what's more concerning is that it hurts at night and gets hard. Because if it's not too small if it's too small, nothing is going to get into it that hurts. If it's large, well, the bowel can go in and out of it. But if it's just the right size, then the bowel or the omentum, a knuckle of fat that hangs down over the bowels, can get in there, and it can strangulate. So it could be an incarcerated bowel, or incarcerated omentum is the word we use for it, because it's trapped in there. And when it gets trapped in there, it can be dangerous. If it's a bowel, it'll cause intermittent small bowel obstruction, or not even intermittent, it can be just a bowel obstruction, and the bowel can die in there. So if it is just big enough, so like between 1 and 2 finger breadths, then I would seriously consider having a look-see with the general surgeon, not your gynecologist, but the general surgeon, and have them fix it for you, because if this is happening every night and it's such a small, easy surgery to do, I would not risk the complication of a bowel obstruction, or for that matter, spend the next year or whatever it is being uncomfortable or in pain when it's so easy to fix. So thanks for writing in. All right, I cannot believe it. We are out of time again. You guys have been awesome. Thank you everyone for joining the conversation. If we did not get to your question, we'll follow up with you in the next few days. A quick reminder that if you'd like to further speak with us, visit kaldascenter.com or give us a call at 920-886-2299. As for tonight, thank you again for spending some time with us, and we hope you have a fantastic evening. Till next time.